correlate and obtain all those data and put it together so that it will make sense and maybe we'll get some statistically significant results from them. So I appreciate everybody's participation in that. Let's see. And so we will start off with the lecture. It is on interpersonal communication skills, which is one of the ACGME core competencies, focusing on the patient-doctor relationship. Our presenters will be Drs. Brian Wexler, who is our behavioral scientist for the residency, and Dr. Kendrick Davis, who is from UCR and came all the way from Riverside campus to be with us today. Hopefully you will enjoy the presentation. Afterwards we will have some questions, so feel free to approach us at any time.
Just want to welcome you. Hopefully the next 40 minutes or so will be a little bit interactive, hopefully informative, and we'll definitely be focusing on the interpersonal communication skills, patient-doctor relationship, with a specific emphasis on how this relates to our role as mentors as we prepare for the family medicine residents to come on board in 2015. A brief outline for today, we'll talk about the ACGME core competencies. I'll address the milestones and what they are. We'll talk more in depth about the guidelines or expectations for interpersonal communication skills. Talk about patient perceptions and how patients see their relationships with their doctors. I'll go into some research. I'm going to talk about 3 items specifically. One I'll go into a little more length, the others will be kind of quick. We'll go into the survey results. We had a pre-survey that went out with the announcement. Dr. Davis has reviewed and has information on the stats and findings of the survey results, which is actually pretty interesting. He's going to talk specifically on facilitating effective communication, and we'll wind down with a conclusion. Now, all of us have certain types of style and characteristics, and when you look at your peers or you look at famous doctor actors from TV, you have a certain idea of how they carry themselves. And I'm going to ask some of you, actually I want a lot of you to chip in. When you look at Dr. House and what you know of Dr. House, and you think of his communication and interpersonal skills, what comes to you? Give me some adjectives. Me.
Who never holds staff privileges anywhere.
Who never holds staff privileges. What else do you get?
Plays good piano.
What's that?
Plays piano.
Plays piano. He's talented. He can also be very brash. Some of you are probably old enough you remember Dr. Leonard McCoy from Star Trek. Just going over some different personality types. How would you describe Dr. McCoy?
Nice guy. Family guy.
Excellent. Just a facts kind of guy, though. He's kind of calculating. He doesn't like to screw around with things. He just wants the information. And Jim, don't give me extra stuff. Be focused, right? All right. Who does not love Dr. Ahmed Oz? What kind of... Dr. Oz. Dr. Oz. What kind of character, how do you look at his interpersonal skills? Kind. Yeah, he's very empathic. He's thoughtful. I mean, who can't talk to Dr. Oz, right? How many of us have qualities?
What kind of doctor is he?
What's that?
Cardiac surgeon. What kind of doctor is he?
What is he?
He's a TV doctor.
Thoracic surgeon. He's a thoracic surgeon, which is unique that he has these qualities as a surgeon. We'll talk more about that. Anybody recognize this person?
Oh my God.
Conrad Murray. Now, he did something right to get the job that he had, but he did something wrong to get to the place where he's at. But you look at these folks and you get an idea of how they carry themselves and how they interact. Who doesn't like Meredith Grey? Maybe a little worried at times, a little anxious. Meredith Grey, raise your hand. And of course there's Dr. Evil. And we don't want to come across being greedy, thoughtless, misanthropic. So how does this all tie in? Well, when we look at the ACGME core competencies, I want to tie this into how we, again, mentor the residents, medical students, and how we relate to our peers. So these skills are not only skills that the residents are obligated to learn, but these are skills that as seasoned physicians and clinicians we should have mastered ourselves. So, just to review, I think probably a lot of you were here in September when Dr. Alexander did the first presentation for UCR. These are the 6 domains of physician competency: medical knowledge, interpersonal communication skills, system-based practice, patient care, practice-based learning and improvement, and professionalism. I'm hoping by now that everybody's very familiar with these, right? Let's hope. So our focus is going to be on interpersonal communication skills. So according to ACGME, the guidelines, this specifies that residents must be able to demonstrate these 6 core competencies, and specifically they would be interpersonal communication skills, and to know these and to show these skills in a way that result in effective information exchange with their patients, their families, with other professionals. So there are several expectations for the residents. Oh, but before we move on, the concept of communication. Why is it important? We have 3 surgeons, and the cartoon says, and that is why we lift on 3. So obviously, not just with the residents coming on board, but with our colleagues, we need to talk about things, we need to plan effectively. So before I get to this, so the expectations of the residents to develop a trusting professional relationship that allows them to inquire and discuss sensitive issues. We'll find out over and over again that one of the key components of practice is the type of interview that you do, being able to conduct a competent interview. No matter what your specialty is, you've got to be able to elicit this information. Another skill is to use effective listening, to gather and provide information to the patients, and to use effective nonverbal, not just verbal, but to be conscientious of your nonverbal skills, being able to explain, question, and to put this all in writing. And the third is to work effectively with other professionals as a healthcare team or as a leader of the team. So, milestones. Are most of you familiar with milestones or not yet? It's a relatively new program that has been brought on board, and these are specifically used to evaluate the resident physicians. And this, again, is in the context of an ACGME accredited residency program. So, I think I can go to the next one. Some of the key issues with milestones, and I'll try to go over these kind of quickly, is that it provides a framework for the assessment of the resident physician. And these are in the different core competency areas. Now, there's a progression to this, through the PGY 1, 2, and 3 years. So as the mentors who are teaching these folks, we get to basically grade them and keep track, and we need to make sure that they meet expectations or exceed expectations. These are designed, again, on developmental attributes that they need to master through the program. So we've got some of our core faculty. Dr. Davis is the medical director, Dr. Gonzalez, our director, Tay Kim. We're going to be responsible, and anybody else participating as a volunteer or mentoring the residents, we need to know that they learn these skills. Let me move ahead to the next little cartoon, actually. And as we learn how to communicate, we know it's important to be empathetic, right? We want to be able to empathize with our patients, but sometimes some people might take it just a little bit too far. Cartoon says, I think you'll find I'm one of the most empathetic doctors around. And for those that can't see it, the patient and the doctor are both wearing a robe with their signs readily accessible. So, what does milestones have to say about interpersonal communication skills? Well, a couple key items, again, and these are part of the core competencies, that we're able to communicate effectively with patients, family, and public, and this is across a broad spectrum of multicultural and social economic backgrounds. And you can't tell me it's not challenging at times. And we have people come in from all walks of life. And you find that those who are on maybe the lower ends, at least in my opinion, I think maybe agree, they kind of get a short shot. They don't get the full assessment. You look down, or people judge them differently because they might look homeless or down and out, or they're too heavy, or they're not the good-looking professional type. And it's really unfortunate. Some of my patient quotes that I'll share later kind of touch into that. That once the doctors know more about the patient, they tend to respect the patient more, and the patient starts to feel better. It's also important that the residents are able to communicate effectively with physicians, with other healthcare professionals, and with other agencies. You know all the time that even in the work you do now, not just as a resident, you've got to be able to cross over and communicate with other people you refer to, or other resources that are helping to manage the patient. And you need to be able to maintain comprehensive, timely, and legible medical records. I'm going to show you a short clip This is with Dr. House, and he's interviewing a patient with asthma. It's kind of a fun clip, but it emphasizes the point that often doctors make assumptions that patients know things, and the other way around, that patients make assumptions that doctors understand. So, focus on it.
Well, sometimes doctors make mistakes, and you need to try twice as hard to fix them. Are you using your inhaler?
All the time. Go through one a week.
You sure you're using it right?
Do I look like an idiot?
No. Why don't you show me how your inhaler works?
So she's feeling a little beaten up right now and silly about not understanding things, but it kind of pushes the point that of how important it is for us to take the time to talk to our patients, to explain and do some education. So let me ask you, what kind of complaints do patients make about doctors? This doesn't have to be about you, but what kind of things do patients complain about? Help me out.
Don't spend enough time.
They don't spend enough time.
They don't listen.
They don't listen. There's more than two. Okay. What else?
They didn't examine me.
They didn't examine me. Right. They saw the doctor maybe for 30 seconds or 2 minutes. They walk in, they walk out. They might tell you things like, there's no eye contact. My doctor doesn't even look at me. He turns his back to me.
He just stares at the screen.
He just stares at the screen, exactly. Also, they've got long wait times, they're not listened to. There's situations where doctors forget their patient's history. One example, this is a patient of mine. About 7 years ago, he went to his specialist and had digestive problems with GERD. After doing some tests, the doctor says, well, I think perhaps if we take out the gallbladder. So the patient goes to the surgery. It's not successful, and he's taking the medications to deal with the GERD. And it's probably about 6-7 years past, and then
What do
still
you mean
seeing the
the
same
surgery was
doctor.
successful? Gallbladder came out, right?
I can't hear it.
What do you mean the surgery wasn't successful? Gallbladder came out.
Well, okay, the gallbladder came out, and the symptoms were resolved. Okay, thank you. Clarification. Good communication. Appreciate that. So it's about 6-7 years later, and the patient still has the same symptoms. You know what the doctor says to him? Yeah, I think you need to take the gallbladder out. That doesn't go over so well for the patient, right? And, so patients often walk away from physicians feeling looked down at or dismissed. Let me look at some specific things that patients say. These are actual quotes. These are patients of mine, but I've changed their identities, okay? Names and identities are not the same. This is an 86-year-old man, been in good health until last year, and when I asked him about his experience, he says, don't sit at the damn computer and talk to me. There's no eye contact. There's no interaction. It didn't go over so well. This patient, Arthur, this is a guy who was a retired professional. His quote was, there's an attitude the doctors have. As soon as he found out I'm a retired professional, his attitude changed in a more congenial way. How the doctor comes on leaves a very important first impression. And that, I brought up before, how we relate to our clients and respect them from whatever walk of life, however thin, however fat, however attractive or ugly, it really goes far and makes a difference. Another client, Garrett. This is a person who's been treated for HIV for about 25 years, has diabetes, has multiple doctors. When I asked him his impression of the interaction, he said, I think all they want to do is bring you in, read the lab results, see you in 3 months. My doctors never ask how I feel, and they never touch me or examine me, look at my ear, at my throat, and I have 3 doctors. So on the patient side, it doesn't really feel very good. This guy, James, he's about 5 years from Medicare, but he's on disability. And he's real quick to tell us that being disabled means you have a disabled income. He used to be in the entertainment world. He was a cameraman, and through some problems lost his ability to hold the camera, so he's ended up on disability. His comment was that the majority of doctors don't communicate well for many reasons, because they're overwhelmed and the amount of time they have is limited, and and their inability to translate doctor ease into patient ease. It's a very uneasy feeling to leave a doctor's visit not knowing the full knowledge of what he or she is saying. So if you imagine for a moment being on that side of the table, it's not very comfortable. This person, Chris, he's about 53, had a history of head trauma, he's got some local physical complaints. His experience is this. When I go, I wait an hour and a half, and I get no more than 5 minutes of that. And he says, I'll write you a prescription, and he's out the door. He's really nice, though, in those 5 minutes. You basically have to get your questions in, and he's out the door. Now, delivery is very crucial. This little cartoon says, have a seat, Kermit. What I'm about to tell you might come as a big shock. And it shows an x-ray of Kermit with a hand inside. Now, can you imagine being in Kermit's position? I mean, really, your delivery is going to make or break maybe the rest of his life. I'm glad that Dr. Gonzalez likes this. That's great. A couple more quotes. All right. This is Mike. This is the person who, he's 64, has a history of multiple hip surgeries and knee replacement. He said, it depends on the doctor. The more specialized, the more clip the communication. You get a real sense that the meter is running. And as treatment went on, they forget what they gave me in the beginning. So he's been given different series of pain meds and different things. And that's been alarming to him. Moving on. This is a movie clip of Alec Baldwin in the movie Malice. He plays, I believe, a neurosurgeon, cardiothoracic surgeon.
I think so.
Thank you, Dr. Craig. And he's in a deposition.
I saw that.
He's in a deposition. He's being sued. And what's important here, the point I want to make with this is how you see yourself, how you come across to your patients, and how you see others. I mean, do you come across as a good listener? Are you maintaining good eye contact? Are you looking for just the facts? Do you skip the chit-chat, the psychosocial rapport building? Is it all about billable hours and time? Or as the scene opens up, he's asked, do you have a God complex?
The question is, do I have a God complex? Dr. Kessler says yes. Which makes me wonder if this lawyer has any idea as to the kind of grades one has to receive in college to be accepted at a top medical school. If you have the vaguest clue as to how talented someone has to be to lead a surgical team. I have an MD from Harvard. I am board certified in cardiothoracic medicine and trauma surgery. I have been awarded citations from 7 different medical boards in New England, and I am never, ever sick at sea. So I ask you, when someone goes into that chapel and they fall on their knees and they pray to God that their wife doesn't miscarry, or that their daughter doesn't bleed to death, or that their mother doesn't suffer acute neural trauma from post-operative shock, who do you think they're praying to? Now, go ahead and read your Bible, Dennis, and you go to your church, and with any luck you might win the annual raffle, but if you're looking for God, he was in operating room number 2 on November 17th, and he doesn't like to be second-guessed. You ask me if I have a God complex? Let me tell you something. I am God.
That would be yes, right?
So,
For the
you
record.
know, it's interesting.
Yes.
I'm going to talk about some of the research pertaining to malpractice, hopefully if we have time. But surgeons are actually looked at different than other doctors. Patients do not expect surgeons to communicate as effectively. Interesting finding.
We get that.
All right, so let me switch gears a little bit, and I'm going to run through just a few research studies on interpersonal communication skills. The first study I want to refer to was out of the Journal of American Board of Family Medicine 2002, titled Physician-Patient Communication in the Primary Care Office, a Systematic Review. Now, just a little quick background. Like a lot of these studies, they found that key to a successful relationship is the physician-patient interview. And it's gonna cross all disciplines, no matter what you look at. They sought to look at existing primary care-based research and to determine which verbal and which nonverbal skills were effective on the part of the physician. So, with an empirical background, they had scoured through articles from 1975 to 2000, again, looking at the interaction between patients and doctors, verbal and nonverbal skills. So, on the verbal skills, what they found, and I'm going to list these, it's a series of things. These are things that are associated with healthy outcomes. Empathy, reassurance, support, patient-centered questioning, encounter length. Even 3 minutes can make a difference. 18 minutes or 15 minutes was shown in the research to make a big difference. Humor. Turns out people who used humor were sued less. That's what the research showed. Psychosocial talk, doing some rapport building. Time spent discussing health education and information sharing. I can't tell you how many times patients in my office as a psychologist will tell me they feel they have a special connection with their doctors because their doctors share with them. They'll say, I have that problem, I've had that experience, or I was treated for this. It goes a long way in building trust and rapport. Other factors that are good verbal that have outcomes are friendliness and providing clarification and summaries to the patients. So you don't rush out, you don't make them feel dismissed, you're actually taking the time. The nonverbal behaviors which stood out. Now these associated with positive outcomes include head nodding. You think, how simple is that? Leaning forward, having a direct body orientation. Not your back, working on a computer, not sitting with your side facing them, taking notes, but actually facing them. Sitting seem to have a better result in terms of working with patients. Essentially, it comes down to being attentive, being mindful, being present with the patient. I would ask, how many of you do that on a regular basis? I hope you would all say you do. And again, it comes down to how do we teach the residents when they come on board and medical students when they're here. So some of the main findings. Again, across the board, the medical interview is the core clinical skill for all healthcare providers. Interesting that when you look at how many patients a generalist sees in their career, which is about 40 years on average, the average generalist sees between 120 and 160,000 patients for interviews. Anybody been doing this for 40 years yet? I don't know if you've tallied up how many thousands of patients you've seen. It's pretty amazing. And across the board, again, they found that the doctors who communicate, that they have much better results in terms of management, and specifically in management as it relates to chronic disease, diabetes, hypertension, congestive heart failure. Now, when the patients are involved, all the better. When they're participating in the decision-making or you're including them on what the choices are, you get a more actively involved patient, your results are better. So, another conclusion, this was rather unfortunate, but this is what the research found, is that physician-patient communication is frequently judged to be inadequate. We may not like to admit it, because we often think that we communicate and interact better than our peers, but this is what the research says. So it's evident that not only is there room for improvement for ourselves, but again, when we're teaching residents and medical students that are coming on board. So, another study.
Brian, I have a question. So, is that really good studies for us? But when I hear the word expectation, I want to know, because I haven't come across this, is there any research that is evaluating the expectations that patients have when they come in? Because as much as we want to meet all of their expectations, my concerns are that patients have unrealistic and completely illogical expectations, and therefore, although that study says we're not meeting their expectations, we're all failing, it might be, to some degree, that their expectations will never be met, and therefore we may be doing better than we thought. Are there any studies that are evaluating expectations?
Again, as far as I understand,
I haven't found them.
when I reviewed a number of studies to look at what the patients expected or how they perceive their doctors and how the doctors perceive the communication with the patients. I think to a degree there are reasonable expectations. I don't think patients expect doctors to be all things, but do they expect to be able to come in and have time of day to explain things, not to feel rushed, not to feel dismissed?
And was that study?
Now, let's talk about it later. We're gonna,
You're going to address it later.
no, well, you and and I can talk about it, because I've got a lot to talk about, and Dr. Davis has things to address as well. But it's a good point. It's challenging, but again, I can't dispute the fact that numerous studies point to the need for improvement among healthcare providers. Okay? All right. So, in another study by Christine Weir called Improving Patient-Physician Communication, this was in the American Psychological Association, American Psychological Association Monitor. I'm just going to read to you some of the key quotes, things that she pulled out from research on patient-doctor care. And think about this. One was, even well-educated patients feel intimidated in the physician's office. Now, I have a lot of physician colleagues, and I fully understand that a lot of physicians are really lousy patients, and they don't seek treatment for themselves, yet they would refer a patient or a colleague for treatment, and they won't do it for themselves. Kind of an interesting concept. Now, also, she says that in the context of a medical consult, people feel uniquely vulnerable, and they believe that if they counter what the physician is saying, that it's going to impact the future consequences of their care. So do you give room for your patients to disagree with you? And it's interesting, again, the communication, the better it is, you get better results across the board. You got better, more active patients, you get better results in terms of overall health. So that's a nice thing. Let me move along. We're going to skip that because I don't think we'll have enough time. We'll have a third study I'll talk about quickly. This was out of Emory University, titled Evidence-Based Competencies for Improving Communication Skills in Graduate Medical Education, a review with suggestions for implementation. Now, again, some of these findings are hard to look at, and some can point out what might dispute it, but the researchers, again, say that physicians tend to overestimate their communication skills. And they found that among orthopedic surgeons, 75% of those surveyed believe that they communicated in a satisfactory way. But when you look at their patients, 21% thought that the doctors communicated effectively. So, again, a lot of room for improvement. Now, at this juncture, got another cartoon. And this brings up the point of, again, listening carefully to your patients, even if you think it's a dumb question. So here's a patient and doctor, and he says, I have a question about my medication. Why is the couple in the commercial sitting outdoors in separate bathtubs? And if anybody here can answer that, all right, so this will bring us to Dr. Davis. He's going to talk about the results of the pre-test survey that many of you did, and also some issues with facilitating education.
Thank you, Dr. Wexler. Good afternoon, folks. To not give you an introduction and to get into a lot of dialogue about my background, what I do for the School of Medicine as the Director of Medical Education is that I really am literally committed to data-driven decision-making. So I do all the data processing. I'm more quantitatively influenced, and so I do more statistics. But ultimately, the idea is that if we process data effectively, then we're more likely to understand what people are learning, how to facilitate that, and how to move in a progressive direction. So what you got in terms of the pre-survey was an adaptation from the ACGME's milestone survey that actually is used on residents to evaluate how effectively they're communicating and utilizing interpersonal communication skills. So what I did is slightly adapt them so it would be something that you could kind of get some reasonable information on. I'm not going to go deep into this, but if you received the link and went online, the survey appears something like this. You have basic directions where I'm letting you know that, as Dr. Wexler was talking about, all the different research that we reviewed. You notice that the language of below expectations, meets expectations, exceeds expectations are the ways in which things are measured. And that's the same type of language that we utilized on the survey that you guys received. Here are a few of the items, and I won't get into the items. You can read them yourselves. You guys are brilliant. But one thing that I want to point out is that if you recall what you looked at when you completed the survey, you had 3 sections. One section was really getting at your self-rated competence in terms of communication and interpersonal skills. Then it was your perception of your peers, your colleagues' ability to facilitate those skills, and then your overall confidence in your ability to do so. Not to belabor the point, but here's something very interesting that I think you should think about. We all should. The research is suggesting that it doesn't have to be physicians. If you think about any research on learners, we could take first graders and ask them about their mathematics skills. We usually overestimate how competent we are. And all human beings do that. That's efficacy. So we're usually overconfident in our competence. So keeping that in mind, in the event that you rated yourself higher individually on your competence and your confidence in your ability to facilitate these skills, it might not be as high as it really is. And that's the first note to keep in mind. The second is that you also evaluated your peers, your perception of your peers' ability to facilitate effective interpersonal communication skills. And like the research has been suggesting, you rated yourselves here individually, you rated your peers here individually. So the only thing that I would ask of you, and it could be a dialogue for a moment, if you have to do team-based, collaborative, cooperative work on patient care constantly, even if you're the last person they see, or you're the first person they see, there's a team of you and a lot of other healthcare professionals interacting. If you're rating your colleagues lower than yourself, is it likely that you'll work effectively with them? Is it likely that you'll learn from them? So that might be something to bear in mind, given the results from the survey thus far. So now here's what I'll do. If you think about what Dr. Wexler has provided thus far, he's given you a rich background. He's gotten your minds active thinking about when I'm in my office, how I communicate, how patients receive me, how would I take that knowledge that I'm gaining and transfer this to residents so they're even more effective than I was when I started. So what I've done is compiled from the research literature we looked at 3 different strategies for facilitating effective interpersonal communication skills. And if you think about it, it's pretty straightforward. This is something you can write on a notepad, hand to a resident, and that's something they could monitor and implement on a regular basis to see, in fact, are they improving in their skills with patients. So if you think about the things that you're being reminded to do, listen to the patient's opinions. It makes sense, because the first thing you're doing is starting to show them that you care and you're really invested in relating to them. Ask them questions about why they're here. What do they think is going on? The first 2 things you've done are automatically put you in what I put as an asterisk, patient-centered communication, because now you've made them the focal point. Make sure that you're present in the moment. And so in psychology, we talk about things like being metacognitive in the moment. And it just means that you're aware of your processing of information as it's going on. With your patient, being present in the moment just means that you're not attending to your next appointment, your previous appointment, your demands at home, but that patient's needs at that time. Actually listen to what the patient has to say. And that can go a long way. Many of us are in romantic relationships, and so sometimes we don't listen to what our spouses or our significant others have to say. So with a patient, you really want to be mindful of listening to what they have to say. If your spouse said, "Were you listening to me?" and you're into the game or whatever else, that might be a key that, just like any other human being, you tend to do that in lapse occasion. So this is the first set of strategies. The second set is pretty similar. There's some overlap. If you think about now, striving to understand the patient, ensuring that you're open and you're courageous to explore that patient's life, because of course there are times when patients come in here with very serious issues that are going on with them. You've got to be courageous enough to explore that, but you have to strive to understand what's going on in their lives. Be empathetic. But I love this one because if you look at the last point, it says discipline caring. So there was a cartoon you saw with a doctor who was highly empathetic. He was so empathetic that the back of his gown resembled the patient's gown. I would figure that being disciplined in your caring might suggest that he didn't need to have that robe on, but you can weigh in and let me know how that is. What do you think about being disciplined in your caring in terms of being empathetic to your patients? Please, by all means, let me know. That gives me a chance to get drink water. And I'm that kind of professor, so you know what that's like. When you ask a question, it wasn't intended to be rhetorical. You guys are brilliant. We can wait till 1, and I'll still give you a chance to answer.
Sometimes you see pediatricians wear a tie with Mickey Mouse or something that is going to engage the kids.
Mm-hmm.
Or lights right there. There's lights on right now.
I love it. And so that ties directly to discipline caring in your interpretation, sir.
Yes.
Excellent, excellent. And thank you for weighing in. And so the last one here with the strategies are relational versatility. And what it really means is like our educational curriculum is all about individualized education plans, which means that you've tailored what you're delivering to that learner, for that learner. Same thing with your patient. It's not a one-size-fits-all. And so you might have a similar condition, but a different patient. You're not likely to be able to treat them the exact same way. And so make sure that you're tailoring what you're doing with the patient to that patient's needs. Last set of strategies, and I'm done. That was beautiful. So it's a combination of the two to a large extent. If you think about the first things that I'm identifying here that were identified in the research, to assess what the patient knows is very similar to getting their opinion. To assess also what the patient wants to know is getting at their questions, like the first set of strategies we gave. Dr. Wexler talked about research where it's getting at other communicative ways of expressing oneself. And so if you think about body language, facial expressions, there's a lot of different ways that people are transmitting information to you. If you're keen to that, you're going to be able to better help that individual. Be prepared for a reaction. The patients came to you for a reason. So after you start to get at their opinions, their questions, connecting with them, relating to them, and you start to express what you're thinking, they're going to react to what you're thinking and be prepared for that. Be empathetic, but of course that means to temper that empathy so that you're not trying to take on everything that patient is experiencing. You end up not being as helpful for the patient. Something that I have to remind myself of even teaching. Slow down. I was in graduate school at the University of Oklahoma. I'm a Sooner. But I'm from California. We have a little different energy, a different culture. We speak fast. And so I got there and I didn't realize that until I was teaching statistics as a doctoral student. I'm teaching multiple regression, thinking that, oh man, I love this stuff. I'm getting into it. It's supposed to be a 2-hour lecture. I finished that lecture in 25 minutes. And the students looked at me like, are you serious? And then a few of them were bold enough to come up to me and let me know, I didn't understand most of what you discussed. And so be mindful of that. What's clear in your mind, what you're excited about, or whatever else may not be that clear for the person you're delivering the information to. So try to slow down and be mindful of what you're doing. As well, keep things simple. And so that's that conversation about the physician ease to the patient ease, and we need to be better about how we communicate things in more simpler forms where people actually understand what it is we're telling them. The last two things, be honest. Be honest, tell them the truth, and be hopeful. And there's always some element of hope. There's a silver lining in everything. And so keep those things in mind, because these are strategies, and you could pick from any of the three, combinations of the three, but at least it gives you something meaningful. Given the research, given the rich dialogue we're discussing, to help these residents become a little more effective at their interpersonal communication skills. Dr. Wilson.
All right, so again, the point that the time you take and how you relate becomes crucial. And just taking that little extra time, maybe to give somebody hope, to give more clarification, it goes a long way. And looking at the last three studies, I'm going to go through these pretty quick as we wind down. And I looked at malpractice, where communication goes bad. It turns out that communication failure equals unnecessary malpractice claims. Here's a little cartoon. It says, "We medical practitioners do our very best, Mr. Nyman. Nothing is more sacred to us than the doctor-plaintiff relationship." And we all know how litigious it's become. And I think physician malpractice insurance is over the top. I don't know how many people have had complaints against you before, or how many maybe had one or two, or how many have had none. But it looks like, according to this study in the North Carolina Medicine Journal, it was titled "Identifying and Addressing Communication Failures as a Means of Reducing Unnecessary Malpractice Claims." This quote really stood out. It said that risk is predicted by the practitioner's inability to communicate effectively and establish and maintain rapport with patients, especially in the face of an adverse event. You make a mistake, a treatment doesn't go the way you want, you fail to communicate this, you're putting yourself at risk. One of the findings in another study out of the University of Chicago, titled "Communication Skills Diminish Malpractice Risk." What they found was that a bad outcome in patient dissatisfaction, again, is a recipe for litigation. In this study, one of the things they found was that it turns out that physicians who had not been sued were the ones who spent just slightly longer amounts of time with patients, which comes out to be really interesting. A little bit more time, you come across as much more effective. The learning to communicate, again, over and over again, learning to communicate, teaching residents to communicate increases patient satisfaction, increases compliance rates, and they have better biological outcomes. They like to participate in treatment, but you got to engage them. You know, and I mentioned before that one possible exception to all of this research on communication were the surgeons. That patients, actually, in the research, patients have less expectation that a surgeon is going to communicate. And maybe that's kind of like Alec Baldwin and Malice. You may want the best cognitive thoracic surgeon, you may not care what kind of personality type he has, you just want somebody who can do the best job. Actually, let me go back to the previous research, 2 things about that. They found that physicians, in terms of malpractice, can be sorted into 3 groups. You've got those that have essentially no claim history. You've got physicians who have 1 or 2 claims, it's very limited. And then you get into a 3rd group that have a high number of claims. And what they found pretty much across the board in different disciplines was that between 4 to 8% of the doctors in any group account for 40% of claims. So you got 4 to 8% that kind of look like bad apples, accountable for 40% of malpractice claims. That encompasses 50% of all malpractice costs. I thought that was just kind of interesting. Do we have time for a little video clip? You guys willing to stick around for about 5 more minutes? Yeah, guys nodded? All right. This was a really nice clip from Patch Adams. And everybody seen Patch Adams? Yeah, a lot of you. This was a scene where he's still finishing his doctorate, and he's before the medical review board deciding whether they're going to allow him to get licensed or keep his status. And it brings us back kind of to those early moments. Maybe there was a time in med school or nursing school or whatever program you're in where you felt idealistic, where you really looked at listening to your patients, giving them the time, giving them the help that they need. And so this was a very kind of passionate response by Patch when he's confronted by the board. Let's see if this works. Here we go.
You've been accused of practicing medicine without a license. It's a very grave charge, son. Are you aware that it's unlawful to practice medicine without a medical license?
Yes, sir, I am.
Are you aware that running a medical clinic without the proper licensing can place both you and the public in a great deal of danger?
Is a home a clinic, sir?
If you are admitting patients and treating them, the physical location is irrelevant.
Yes, sir. Will you define treatment for me?
Perhaps treatment would be defined as the care of a patient seeking medical attention. Have you been treating patients, Mr. Adams?
Yes, sir, I live with several people that come and go as they please. I offer them whatever help I can.
Mr. Adams, have you or have you not been treating patients at your ranch?
Everyone who comes to the ranch is a patient, yes. And every person who comes to the ranch is also a doctor.
I'm sorry.
Every person who comes to the ranch is in need of some form of physical or mental help. They're patients. But also every person who comes to the ranch is in charge of taking care of someone else. Whether it's cooking for them, cleaning them, or even a simple task as listening. That makes them doctors. I use that term broadly, gentlemen, but is not a doctor someone who helps someone else? When did the term doctor get treated with such reverence as, oh, right this way, Dr. Smith, or, excuse me, Dr. Scholes, what wonderful foot pads, or, pardon me, Dr. Patterson, but your flatulence has no odor. At what point in history did a doctor become more than a trusted and learned friend who visited and treated the ill? Now you ask me if I've been practicing medicine. Well, if this means opening your door to those in need, those in pain, caring for them, listening to them, applying the cold cloth until a fever breaks, if this is practicing medicine, if this is treating a patient, then I am guilty as charged, sir.
Did you consider the ramifications of your actions? What if one of your patients had died?
What's wrong with death, sir? What are we so mortally afraid of? Why can't we treat death with a certain amount of humanity and dignity and decency and, God forbid, maybe even humor? Death is not the enemy, gentlemen. If we're going to fight a disease, let's fight one of the most terrible diseases of all, indifference. Now I've sat in your schools and heard people lecture on transference and professional distance. Transference is inevitable, sir. Every human being has an impact on another. Why don't we want that in a patient-doctor relationship? That's why I've listened to your teachings and I believe they're wrong. A doctor's mission should be not just to prevent death, but also to improve the quality of life. That's why you treat a disease, you win, you lose. You treat a person, I guarantee you'll win, no matter what.
So again, the idea with that clip is just to bring you back to some of that, maybe that idealism that you went into grad school with, and in the concepts of spending that time with your patients. It may only be 30 seconds, it might be 3 minutes, maybe you have 10 minutes, but it really makes a difference. And hopefully, in the concepts we've covered, talking about interpersonal and communication skills, you'll be able to take some of that with you, not just for yourself, but again, I keep bringing up the fact that we're looking forward to the residents coming on board. And personally, I'm looking very forward to the residents coming on board and being able to observe their communication and mentor them. I think the rest of the people on the team are as well. So, as we wind down, just kind of a review, the things we talked about. We reviewed the ACGME core competencies, talked about the Milestones project and how it's based on the developmental progress and expectations of residents. This addressed various aspects of interpersonal communication skills, patient perception. Talk about some of the research, which over and over again points to the importance of the basic concept of communication. We talked about ways to facilitate more effective communication. And as we wind down, I'll just leave you with this quote, and this says, "The patient will never care how much you know until they know how much you care." I thought that embodied a lot right there in terms of how we communicate. My name is on there with the email, and Dr. Davis, if you want to contact us, you can reach us at our email addresses. There are an abundance of references and resources regarding communicating with patients and doctors. And there's probably close to 80 or so references that I've written out and Kendrick has written out. So if you'd like access to this, let us know. And I guess this is where we open up for a few minutes if there's questions.
Oh, you guys are a wonderful audience. It's outstanding. Well, thank you for your time. That was awesome. You have a question, sir?
Thank you. Thank you. Do you believe that, do you believe that doctors of today communicate less than doctors of tomorrow or of yesterday? When the biggest complaint I hear from patients is that when they go see their doctors, all they're doing is looking at a screen, knowing how much there's demand now with, electronic record recording and time constraint for doctors and physicians. Do you think physicians communicate better today than they did in the past, or the other way around?
I think there's going to be a lot of different angles on it. Again, as a psychologist and working with physicians and reviewing a number of research articles, my impression, I think there's a lot of different pressures on physicians and health practitioners today than there were even a decade or 2 decades ago. I think it's a lot more complicated with all the digital data, electronic media, and I think it becomes distracting to a patient. So while you might be looking at some digital, MRI or CAT scan, or patients don't know what you're doing. They know that a doctor walks in a room, they pick up a chart, they look at you, they might ask a question, and they walk out and they think the doctor's coming back, but then they only find out that the nurse comes in and says, "Okay, we're done." So, I think a lot of it is kind of, it's doctor specific. Because I think doctors, this is my impression, and I think some doctors do take the time, they have the mindfulness and the skills, and they want to make that connection. Now, I know specifically with my patients and my private practice, that when patients tell me that when they do connect, they feel special. They tell me that I don't think my doctor talks to his